always a pleasure to see everyone. And for those who don't know me, my name is Ashok J. Prasad. I'm an interventional cardiologist in the community for many years. And today I'm going to speak to you about a new and novel therapy for osteoarthritis of the knee. And hopefully by the end of the talk, we'll answer two questions. Number one, why is a guy who spent the last 15 years of his life waking up in the middle of the night to open up arteries going to talk to you about closing them? And then number two, how does someone who's been working with the heart and the arteries and their tributaries now talking about orthopedics? And hopefully at the end of this, we'll find some sort of marriage of the two. All right, so the agenda, I'll keep it very simple, and if I speak too fast or unclearly, just don't hesitate to stop and I'll be more than happy to clarify. But we're going to talk about arthritis and just the basic mechanisms and the biology behind it. Then we'll talk about a quick anatomy of the knee. This is not something that you would want to be repeated in medical school, or if you talk to your orthopedic doctors, you don't want to repeat the anatomy of the knee according to Dr. Prasad. But I'm going to keep it very, very simple and kind of germane to the procedure I'm going to do. We'll talk about the symptoms of arthritis, the standard therapies, and then we'll talk to the crux of the talk, which is geniculate artery embolization and which patients qualify for it, what it is, and what are the benefits, and then we'll talk about some outcomes and conclusions. Okay? So, how many people here have arthritis, whether it's of the knee, okay, good. That's great. I'm starting to feel it too. So osteoarthritis is a degenerative disease of the synovial joints. So synovial joints are all the joints of the body that have these capsules around it, right? The hip, the knee, the hands. It is the leading cause of adult chronic pain and disability. The leading cause not only in the country, but also in the world, okay? 595 million people worldwide are living with it. And this is actually 156% higher in the last 20 years. So in the last 20 years, we've had such an increase in osteoarthritis, mostly for multiple reasons, including advancing age, okay? And it does subsequently cause a huge economic burden on healthcare, about $27 billion. It's the most common reason for total knee replacement, all right? Now, what are the risk factors of arthritis in general? And then we'll talk about knee arthritis. The most common and the most easiest to understand is age and the aging population. Many patients, and most of the population above 60 years old, have some sort of chronic pain from the knee. Second, something that is very unique to Western and developed countries is the rate of obesity and the amount of pressure that's constantly been placed on our joints over a lifetime contributes to wear and tear and leads to chronic inflammation. Females tend to be a little bit more at risk than males. Part of it is due to the bone density and then the onset of osteoporosis, which seems to be a little bit more aggressive in females as we age. And then finally, if you have a history of prior trauma or if you play professional sports, obviously with the constant impact injury, it exacerbates and accelerates inflammation. All right, anatomy of the knee. 101, according to Dr. Prasad, all right? There are a lot of parts to the knee. There's the bones, there's the cartilage, there's the capsule, there's the meniscus, there's the tendons, the ligaments, the fat pads, the circulation, the arteries, and the nerves. You only need to know 3 or 4 things. First, they're the bones, then the cartilage, then the capsule, and then the arteries. The rest of it is just fluff, okay? So the bones, so if we talk about what a joint is, right, it's where the 2 bones come together and they have to move in relation to one another to help us to do the things that we need to do as human beings. So if we start at the basic level of the bones, the knee bone is the composite of really 3 major bones, and you can say 3.5. It's the femur, which is your thigh bone, which is the biggest bone and the longest bone in the body. It meets the tibia, which is at the knee. It's the shin bone. There are 2 bones at the knee. There's the tibia and there's the fibula, which is on the side but doesn't articulate with the knee itself. And then there's the knee cap, okay, which is the patella. So as far as we know, as far as we need to understand, you have the femur, You have the tibia, and you have the kneecap or the patella on top. Now, how do they all relate to one another? If you have bone on bone, you're going to hurt. And some of you probably already do hurt. So the way that we're able to articulate between these two joints, these two bones and through the joint is the bones are covered with a nice, shiny, slippery, frictionless material called cartilage. And the cartilage is a very, very important part of the joint. It covers the opposing parts of the bone. It reduces friction. It allows all the movements to happen. As long as you have cartilage, the bones work, and the bones don't inflict any pain, and they're able to perform all the motions, the dynamic that we're able to do in our human life. So you need the cartilage to cover the bones, and it provides a smooth surface that allows the bones to move in relation to each other without any pain or disruption. The cartilage is mostly avascular, which means that there's not arteries that penetrate it. Okay, you need it to have a nice, uninterrupted, shiny cover over it, and it's usually not very, it's aneural, meaning there aren't a lot of nerve fibers in it. However, under the cartilage, which is the bone, is vascular, and there's nerve fibers. So if you get to if you wear away cartilage to the point you're now bone, you're going to have a lot of pain and inflammation. Osteoarthritis is simply defined as this, okay, is destruction of the cartilage. All right. If you don't have destruction of that cartilage that covers your bones, you don't have arthritis. All right. Osteoarthritis of the knee especially, but osteoarthritis in general must involve or results in the destruction of the articular cartilage that covers the opposing sides of the bone. So that's one thing I want you to remember, because we're going to come back to it later. So we talked about the three bones. We talked about the cartilage that covers the bones. Now, how do you keep it all together? You have a capsule. A capsule is a membrane that supports the joint and also has a lining in it called synovium, which is special cells that secrete clear fluid. And the fluid not only lubricates, but it also nourishes the cartilage. So you have the bones, you have the cartilage on top of the bones, and you have the capsule. And the capsule is filled with clear fluid, and it provides nourishment. Okay? And it is highly vascular, meaning there are arteries and branches that supply the capsule and brings nutrients and cells, and in some cases when it gets inflamed, inflammatory mediators, but that's how the knee stays healthy. It's the capsule, okay? And then finally you have the arteries. Like I said, there's only 4 parts that we need to know about the anatomy. You have the bones, you have the cartilage, you have the synovial capsule, and then the arteries. And the arteries, we call them the geniculate arteries, or the genicular arteries. Genu is Latin for knee. All right, and there's six geniculate arteries. There's 3 on the lateral side, and there's 3 on the medial side. And they anastomose, meaning that they form a little lattice or a network wrapping around the knee. And between these 6 arteries and their branches, they nourish and supply the entire knee joint. Okay, and we'll come back to why we need to what's the importance of these branches, because that's the primary target of the procedure that we're going to talk about. And they all come off the middle artery, which is the popliteal, which is the big artery that if you feel behind your kneecap, that you feel a pulse, that's your popliteal artery. And from the popliteal artery, you have the 6 genicular arteries. Okay, everyone following so far? All right, we're all knee anatomy specialists now. So what happens when you get arthritis? We already said what's the end result. What's the end result of arthritis? You have inflammation, but what happens? Pain. No, but what did I say is the end result? Bone on bone. So you lose cartilage. So we have to figure out what is happening that eventually makes you lose the cartilage, and it's inflammation. All right. So on one side, you'll see this is a healthy knee joint. You have the 2 bones. You have the articular cartilage that's right here. Everyone can see the nice blue. This is the synovium, all right? And then underneath the cartilage, you have the bones. When you have years of wear and tear, when you have injury, what does any part of the body that is injured, it has to start healing. Inflammation is the body's ways of initially healing. So if you imagine yourself getting a cut on your skin, first of all, it stops bleeding, has to clot. And then you'll notice in the next couple of days it turns a little bit red. It's a little bit indurated, but then it slowly heals, and that's inflammation. Same thing happens in the knee joint in a little bit more complex manner, where there is some wear tear, there's some injury, and now the bone and the cartilage and the synovium saying, hey, we need to heal. And what does it do? The vessels that are already nourishing it bring more inflammatory cells and mediators. Now, these mediators are designed to help the joint heal, but the problem is, as you continue using the joint, it never truly heals. So what happens is this inflammation, which is supposed to be short-lived and short-term, becomes very chronic, because it's not like you can not use your knee or stop walking. So over years, you have chronic inflammation, and it's really a cascade of issues. So a cascade meaning that there's this constant cycle of inflammatory cells coming in, destroying the tissue, causing more inflammatory cells to come in, bringing more, causing more destruction. So you have this kind of vicious cycle of inflammation that continues to wear down the synovium and the joint capsule. So the chronic inflammation leads to joint destruction. And joint destruction, I mean specifically cartilage. One part of the inflammation is something called angiogenesis, which literally means the birth of new arteries. So new arteries are created in the areas that are inflamed, because the body's saying like, hey, this is not healing, we need to bring more mediators in, so they start growing new arteries. So this mechanism called neoangiogenesis, where new arteries are now growing into the capsule, bringing more inflammatory mediators, which leads to more destruction, which leads to more inflammation, which leads to more arteries, continues, and it ultimately leads to wearing down of the joint. Where you see here, it's a nice and smooth cartilage. Here you can see over years that cartilage has done what? Has started to wear away, okay? And when you look at the bone on an x-ray, that cartilage, which usually you can't see on an x-ray, you see it as a space, that space starts to get narrower and narrower and narrower, until someone one day, the orthopedic surgeon will say, now you have bone on bone, because that space is pretty much not even there. And then this results into the symptoms. Right? The chronic inflammation, because now there's neovascularization, meaning new arteries, there's new inflammatory mediators, it causes swelling, it causes pain now because the nerve fibers are being irritated, it causes stiffening just partly because of the swelling, and also partly because you have all these processes happening, and then finally leads to joint instability, where the knee can't even support your body weight, and then that's when it gets really dangerous, because now there's risk of fall. So this is a very busy slide, but I want you to look at two things. The end result of the process is cartilage destruction and synovial neogenesis, which is the birth of new arteries. Okay, and these arteries really destroy the capsule, just like if you've ever seen, I'm from New York City, like you've ever seen like cobblestones or pavement, you can even see it here, where you see the weeds kind of cracking through the pavement. And that's basically what's happening, that you have these small pathological vessels that are now infiltrating into the synovium and now starting to destroy it, okay? And that, I want you to keep that metaphor in mind, because of what I do. We're basically trying to kill the weeds between the pavement. So now this is looking at a regular x-ray. Now an x-ray can just tell us, I mean, it looks at the bones, it looks at the joint space, and this is a normal, healthy joint space. The reason you don't see the bone on bone is what's there. The cartilage is there. Very good. And you can see that there's no bone spurs, or we call it osteophytes, that are these small little reactive bone growth that happens when you constantly have injury. So we actually, when we look at arthritis, when you go see an orthopedic doctor, or when you get your x-rays, we actually measure how bad the arthritis is based on how narrow that space is getting and how much of those bone spurs that you're developing. So if you have a normal, if you have very early stage of arthritis where you still have a pretty preserved joint space and very little osteophytes or little bone spurs, you're in stage 1. But by the time you get to stage 4, you've lost a lot of the cartilage. You start seeing that the space is very narrow, or literally you'll see sometimes bone is literally on top of bone, and you'll see a lot of small osteophytes or bone spurs. Okay, this is an x-ray. So you can see here, this is normal. You have a nice, healthy space, no real bone spurs. And then as you progress in your disease, in the arthritis, you see how the space continues to narrow, narrow, narrow. And here, It's literally bone on bone. And I don't know if you can see it clearly here, but there are areas where the bone is deformed and you have a lot of small bones. So grade 4 is really advanced arthritis. And this is when knee surgery is really the only option, okay? So the symptoms and signs are basically in accordance to that: swelling, instability, pain, immobility. And when we talk about therapies, initially when you're diagnosed with it, you take your ibuprofen, your aspirins, your anti-inflammatory medications, which number one, it's not recommended to take forever because they do have side effects. And number two, they're not as effective because this inflammation continues to occur. Physical therapy, exercise, weight loss are the initial recommendations. And then you may go see an orthopedic surgeon. They'll advance with more advanced pain medications. Sometimes they'll give you cortisone injections in your knee, sometimes other substances. And then finally to the point, so basically what we do is they try to buy time that you can use your native knee until the point that you can't, or it's dangerous or it's unsafe, and then say this is the time for knee replacement, okay? Geniculate artery embolization, the procedure I'm going to talk about, falls between medical therapy and right before surgery. So I don't want you to think or assume that this cures arthritis. This doesn't replace total knee replacement. Think that it will buy you some time, okay? Whether you're not ready for the knee replacement or you're not, or the surgeon doesn't think you're appropriate because of other risks like weight and things like that. But genicular artery embolization is just an option on the treatment. But ultimately, the treatment of severe arthritis is knee replacement. And so I tell my orthopedic surgeons that this is in no way in conflict with what they do. This, if anything, is just another option for them to consider before they take the patient to the OR. So let's actually talk about what the procedure is. So genicular artery, everyone understands, is the arteries of the knee. Embolization means that we're going to close them. Okay, we're going to close the arteries. And what's the basic patients that we would do? I'll do anyone. Okay. Usually, obviously, because of the prevalence of the disease, it's usually in our older patients, so 50 to 80. They've gotten to the point where the pain is severe, moderate to severe, irrespective of prior therapies. So they've had their NSAIDs, they've had their pain medications, they've had several injections of the steroids. They've done everything, and it's still very painful. We try to do more advanced stages of arthritis, so we don't try to do stage 1 when it's initially starting. But 2, 3, and sometimes 4 is reasonable. Okay, these are the patients we see that seem to benefit from it. If they have local knee pain and they don't, and the only contraindication, the only time that we hesitate is if you have vascular disease. So if you understand vascular disease where you develop plaque in your arteries, one of the mechanisms that arteries continue to function is they create new arteries around the plaque. So around the knee, if people have vascular disease in their legs, they create this network of bypasses around the blockages. So we're very careful not to close too many of those arteries because you need those arteries just to keep your foot attached. So peripheral artery disease is not an absolute contraindication, but it is a point where we do exercise a little bit more caution in choosing these patients. But otherwise, most patients who have moderate to severe arthritis with good arteries, we can do this treatment, and it's safe. So from understanding that we have cell destruction here and the new vessel growth, genicular artery embolization is trying to disrupt it at that point, early on. We're trying to prevent the actual growth. We're trying to stop the growth of new vessels. All right, so what do we do? Here we bring a catheter down into the main artery, which I said was the popliteal artery, right? That's the artery behind your knee. And then we select one of the 6 genicular arteries. We put a catheter in, and then we inject material that closes the terminal branches. So we find the branches that come off of these parent branches that are causing the inflammation, okay, that are penetrating into the capsule, that are the weeds kind of sticking through the pavement. And then we bring the catheter as far as we can to right where those arteries are, and then we close them. And how do we close them? We close them, first we use an antibiotic called imipenem, okay? The interesting with imipenem is, number one, it's an antibiotic, but if you take imipenem and you mix it with contrast, it becomes like a gel. And we can inject it very safely into these terminal branches, and it shuts the arteries down. And the beautiful thing about imipenem is that it's absorbed. It's absorbed very easily. Within 30 minutes, it's broken down, and there's nothing left of it. So it closes the arteries down, and the arteries don't open again, and then the body absorbs it. The second thing that we do is we actually inject small microparticles called embospheres that are about 100 to 300 micrometers into it. We don't use this as much. We use a little bit. So we initially will inject with the Primaxin, the antibiotic, the imipenem, and then at the end of it, we'll put 0.1 or 0.2 cc's to kind of just pack it in. These we don't use as much, but these are actually very effective, and this is the final stage. So between the imipenem, the antibiotic, and the embospheres, we close those small branches. And it's called pruning because you're not closing the parent vessel down. You're just trying to close down those branches that are cracking through the cement. Okay, and the way we see it, so here is another picture. You see the catheter here. We find the branch, and these are the terminal. These are the abnormal arteries. You see how they're kind of like finger-like penetrating in, and then we inject the particles until we see that they're gone. Now we can see the way that these abnormal arteries look like is something what we call a blush. So when we inject it with the contrast and we take a picture under the X-ray, there's a very distinctive misty appearance that it has. And then we know that that's the area because that's the inflammation. And here you can see, right here. So again, this is the artery. We're bringing a catheter here. We inject dye to just see where the artery, and you can see this little area here. You see how it's kind of like, it kind of highlights? That's inflammation. That's where all those little microvessels are going in and bringing the inflammatory molecules and cells and mediators. And we bring the catheter as far as we can, maybe like up to here, and then we'll inject the imipenem, and then followed by the embospheres. And then we take a picture afterwards, and this is what it looks like. Yeah. And see, and two things I want you to, I mean, one, you can obviously see that the blush is gone, but more importantly, you can see that the parent vessel, the normal vessel, is still open, right? So it does very little, it does no damage to the knee, but it just shuts down immediately the arteries that are caused. And you can see, like, this is a hot, we always say that, that the joint is hot because it's lighting up. And then after we inject it and take the picture again, it disappears. Does everyone see that? Okay. Here's another picture. This is the superior lateral geniculate artery. The catheter is here. We bring a microcatheter up to here, and we take a picture, and you can kind of see here. You see that mist right here? Okay. We inject the embolic agents, and then we take a picture again, and it's clear. Okay. And then the pain relief is almost immediate when they get off the table. If not, at least within the first 2-3 days. But this is, from a technical standpoint, you can understand that we can see, this is how we can see it, because we can see the abnormal cells appearing as this blush, and as soon as we close it, and we check to make sure that the blush is gone, but more importantly, that the rest of the vascular architecture is preserved and untouched. Okay, so now let's look at what the data looks like. So when we talk about outcomes, really, this is the most important thing for you. Is it safe? Is it successful when we do it? And is it technically successful? And is it, more importantly, clinically successful? And we'll look at each of those. So from a safety and complication, it's a very, very safe procedure. The most common complication is something called non-target embolization. So you have to imagine we have the catheter in there and we're injecting these particles. Sometimes the particles can go into other arteries that we didn't want it to. And usually they're the arteries that go to the skin. So non-target embolization is when the particles go to other arteries besides the small vessels that we're trying to target, and they cause most of the time just a skin rash. And the skin rash we've seen, and it usually resolves within 2 weeks. Usually at our practice, we'll treat you preemptively with steroids, and it's not something that's to be concerned about. Second, we also noticed that complication with the skin rash occurs more when we use the embospheres, those particles, rather than the Primaxin. So we switched, and we use more of the antibiotics, and we use very little embospheres, and the non-target embolization, the skin rash, has been markedly less. Third, the one way that we can prevent it is you have all these small vessels. When we do the procedure, we actually wrap your knee with ice bags. So when you have ice on the skin, it closes those small cutaneous vessels, so the particles don't want to go in there because it's shut down. So we do the procedure with ice packs around your knee, and that also reduces the skin rash. But the skin rash, the modeling, the discoloration, we haven't seen any ulceration. It lasts less than 2 weeks, and it's very safe. So the bottom line is that the safety profile is very, very favorable. Non-target embolization is reduced by using less of the embospheres, using more of the Primaxin, and then using the ice packs around the knee. The second common complication is bleeding. Now, we don't have a bleeding complication because most of the prior studies were done with accessing your groin. So if I've done catheterizations on any of you in the hospital, I usually go in the groin, although sometimes now I go in the wrist. Certainly with bigger arteries, there's higher risk of bleeding. And so this paper quoted 10%, but we don't have that because we don't go in the groin for this procedure. We're the only lab that actually goes in the foot. So I'll go backwards. Instead of going from the groin down to your knee, I'll find one of your arteries in the foot and go back up. So our bleeding rate is 0, okay? So really the only complication is the skin rash, the non-target, and we've even reduced that. Other complications include paresthesia, which we've never had, and then fevers, which we've never had. Okay, so overall the bottom line is the procedure is safe. Okay, number 2, technical success, meaning if we choose an artery, how many of the arteries can we shut down? If the definition of technical success is embolizing at least one target, the success rate is 84 to 100%. Now, there's one article that quoted 84%. If that wasn't in the meta-analysis, it's pretty much between 95 and 100%. We're always able to find an artery with a branch and then close it. So the technical success, meaning getting rid of the blush, is between 95 and 100%. Okay, we can, as long as we find the blush, we can eliminate it. But more importantly, like for me, it's important if I'm technically successful with the procedure. But for you, you need to know, like, what do you feel? Do you feel better? So this is what's more relevant. So the things that we look at and we measure is, does your pain get better? Does your functionality, the ability to do stuff around the house and in your life improve? And does it improve your quality of life? So these are things that are difficult to measure, but we do measure them. So when we look at pain is a very subjective metric to measure, but we have a scale called the visual analog scale. You've seen in the hospitals like the happy face, the mad face, and or the scale. So we have the visual analog. You'll usually get a ruler and we'll say, listen, this is no pain, this is the worst pain. When your knee pain is at its worst, move it where it is, and you just put an X and we measure it. Okay, so it's on a scale of 1 to 10, and we measure, and we'll measure it right before you have the procedure, we'll measure it a month after the procedure, we'll measure it 6 months after, and we'll measure it 1 year after. Okay, so that's the way we measure pain. That's called the VAS pain scale. The second thing we look at is looking at your functional capacity. The most, aside from the pain, the other consequence of having chronic knee arthritis is you're not able to do the things that you need to do at home. So we can measure how much of your functional capacity has been debilitated, has been affected, and we can use surveys. There's a Western Ontario and McMaster University survey, we call it the WOMAC or the KOOS scale. You'll receive the WOMAC scale, and this just looks at different functions that you have to do, from pain to walking, and then it gives you a scale. The higher the scale, the more debilitating the knee pain is on your functional capacity. So we look at pain with the VAS scale, we look at how bad it's affecting your function with the WOMAC scale, and then we're going to measure both. Now, you can see this chart. So this is looking at the VAS scale. You can see before the procedure, the pain scales are very high, right? 8, 9, 10. This is immediately after the procedure, and what do you see? You see a quick drop, and this is within 1 month. And more importantly, you can see that the effect lasts for several months. So from a pain standpoint, the pain is reduced within the first month, and it's pretty significant. These are different clinical trials, and you can see across the board that VAS scale improves within a month, okay? Second, functional capacity. This is looking at the WOMAC. You can see that they have high WOMAC scores before, meaning the higher the score, the more debilitated, the more limited they are. After the procedure, within a month, they're able to do more. And this is also sustained, okay? So both the VAS and WOMAC scales show that they're reduced 30 to 50% within 1 month, and the effects last for up to a year. Okay, and usually that makes sense because it takes about a year for those new vessels to grow back and start causing the inflammation again. So, and then the third thing is the effectiveness is actually less the more advanced your arthritis is. Meaning, if you have bone on bone, right, it's not just these arteries that are causing the bone, it's literally the bone on top of the bone is hurting you. So in those patients who have KL class 4, they may not get like an 80% reduction, they may get a 30 or 40% because their pain is not just from one thing, it's happening for just the fact that they have no cartilage at all. So this seems to reduce the pain earlier on in the disease process than at the end stages where knee surgery seems to be the only thing, okay? So conclusions. Osteoarthritis is a leading cause of adult chronic pain and disability, and the most common joint is the knee. Second most common is what? Hip. The mechanism of knee arthritis is more than wear and tear, but it's chronic inflammation that leads to angiogenesis that ultimately leads to what? Cartilage destruction, right? And when you have no cartilage, it hurts. Lifestyle and non-pharmacological and pharmacological therapy are the first line, but geniculate artery embolization is a possible option for symptom relief for candidates who aren't ready for surgery yet. Okay? It is minimally invasive, it is highly technically successful, and it contributes to reducing the pain and the inflammation, and you just do it by getting rid of the blush. Okay? It is safe, and the most common complication is skin irritation from non-target embolization, which we reduce, and it is effective to reduce pain and improve functionality by at least 50%. Okay? And it does not cure arthritis. So the two things it won't do, I don't want you to think that this is going to regenerate your joint. It's not. Number two, if you have instability, if it's to the point where you not only have pain, you don't have functional limitation, but now it's just you can't even stand, this is not for you. I wouldn't, and I've had patients that I've had to turn down because the knee stability means that you need strength in a new joint. And I don't do it on patients who also have instability of the joint. It doesn't cure it. But it's a good, I have some patients who the orthopedic surgeon aren't ready to do surgery just because their BMI, their weight is very high. Then they'll send them to me and I'll try to take the pain and then they can try to do physical therapy and weight loss and then reconsult the orthopedic surgeon for the knee replacement later. So what should you do if you have knee pain? Number one, confirm your diagnosis. All knee pain doesn't necessarily mean you have arthritis, right? There are other things in the knee like the meniscus, the ligaments, the muscles. So I would definitely get x-rays if you need an MRI. But I think seeing an orthopedic surgeon, especially if it's chronic pain, if it's limiting you, is a good thing. You should have an orthopedic surgeon on your team. Number two, have the knee examined. Have someone to look at it. I mean, when we see patients for these, I examine it, I feel it, I touch it, I move it. I find where the pain is mostly, but you need to have a good knee exam. Rule out other causes of knee pain. So don't always assume it's arthritis. Make sure it's not meniscus disease, ligament disease, tears, because these things aren't going to be helped by the procedure at all. These need actually orthopedic and arthroscopic therapies. If you have arthritis confirmed, assess the severity and then first resort to lifestyle and medical therapies. Okay, I would follow what the orthopedic doctor says and look for non-invasive therapies. If surgery is an option or is not an option or you want to wait, then consider evaluation for the procedure and just come to our office. You don't have to be a heart patient for it. And then we can look at it. I'll look at the x-rays, we'll look at the knee, and as long as it's nothing else, we usually were able to do it. Okay? Thank you.